So I'm going to start this off by asking you a question, and it's going to be a really tough question. How many of you are here for the first time? All right. Okay. Okay. I may actually take it out of the holder shortly, but all right. And then the second question is that I'm going to be talking about a type of medical imaging. It's called SPECT imaging. I'll discuss other types of medical imaging as well, but how many of you have ever heard of SPECT scanning or SPECT imaging? Well, okay, so there's some familiarity, all right, okay. So first of all, let me just start out by saying, and maybe I can just get away from this thing because I don't need to stand there. So bottom line is that I've been speaking at this conference for at least since 2006. And what I'm telling you about, in other words, I'm more interested in giving you a context to hold on to some ideas rather than to give you a whole bunch of slides and minute details. So I want you to, when you leave the presentation, to say, okay, I got how SPECT imaging fits into medical imaging in general, how I could or could not access this type of service, who to talk to about it, and how to make some critical decisions about whether or not you could actually access this type of service in your community. How many of you are here from the Kansas City area? Okay, so I'll say a little bit about that, but the point is that, first of all, is that my colleague, Dr. Henderson, who just came in the room, is that he and I worked alongside each other in a number of ways for years. And it was literally, it's our second anniversary in the sense that he and I had breakfast together 2 years ago at this particular conference, and we said, why don't we pool our resources, synergize our clinical efforts, and so we can even service, give service to a greater number of people. And just combining our efforts it enables us to spread our services now from Southern California through Colorado, where Dr. Henderson is primarily. We also can give some service in Florida, and we're talking with other individuals about working with them, working on collaborations, so that we don't have to build scan centers all over the place in order to make this technology available. So in the course of doing that, Dr. Henderson, who's in Denver, and Dr. Uszler, that's me, who's been known as Dr. SPECT for a long time, combined our activities with a particular focus on how do we use brain function imaging to guide an understanding of what's actually going on in the brain of individuals, and then how does that help us to know what therapies would be most appropriate based upon brain function information, not just upon behavior information. And to find out more about us, this is the sort of like the end of the commercial. You can go to neuroluminance.com or nlbrainhealth.com. And so, as I said, we're actually looking at, you can see this one, could maybe. So we're looking at a spectrum of brain dysfunctions. In other words, you may be here looking about autism or autism spectrum disorders. What I'm describing to you applies to any type of brain dysfunction. And as I say, we're scanning children from 2 to 92. So that even though we're focused on the autism spectrum at this point in time, this technology exists, and we can help you with this, whether this is a person who's got chronic fatigue syndrome, if somebody's got a traumatic brain injury, somebody has questions about dementia or stroke or what have you. Today the focus is, of course, on what is the brain function in individuals on the autism spectrum. How does this information help you? Just a little bit about my background is that the thing that I want to just point out is that a lot of my colleagues have some family member as a special needs. I don't have a special need child or grandchild. My way of getting into this world, besides conversations with Dr. Kaplan, was that 2 physicians from the past just contacted me. One is a Dr. David Hughes. Neither one of these individuals are, let's put it this way, they're with us in spirit right now because they passed on. But Dr. David Hughes, 20 years ago, called me one day and said, we're treating kids in the cerebral palsy spectrum with hyperbaric oxygen therapy. We think we're doing some good. Could you help us look at their brains and tell us if what we're really doing? And I said, on one condition, and that is, tell me what is hyperbaric oxygen therapy, because I don't know. So that was my learning point about hyperbaric oxygen therapy and my connection with that field for the last 20 years. And Dr. Neubauer was running a hyperbaric clinic for the Ocean Hyperbaric Neurologic Facility in Fort Lauderdale. And this is a relatively small world, so I'm sort of wired across, networked around the country. So I learned a whole lot from him. He was a wonderful human being, and just appreciate the contribution that both of these individuals were to my life. And their contribution gets paid forward in you. So right now today, although there's these other applications, we're going to say, okay, what can we help you to know about autism or what the brain is doing by looking at brain function imaging? Now, in terms of diagnosis of autism, all of you know, I'm assuming that you know, is that the diagnosis of autism is really based upon clinical observation. So we're not using brain function imaging to make any diagnosis of autism itself. Also is that, and as you work with physicians and healthcare providers, many of them, when they think about looking at the brain, if there's a question about it, the first thought of most doctors is anatomy. So one of the first things they do is order an anatomy scan, an MRI study. And there's enough data now and experience to know that in most individuals on the autism spectrum, and I think some of you are shaking your heads, you already know, is that the MRI scans look normal. Now, it's not a bad thing. It just means that this is really not an anatomic abnormality. It's a brain function abnormality. So it makes sense to use some brain function imaging, and we're going to talk about that in detail, because virtually all of the individuals on the autism spectrum have some atypical brain function. Notice here, I'm not saying there's anything abnormal. It's just atypical. So we no longer speak about people or describe scans in terms of somebody's abnormal. They're not. Things are just atypical function. And because this is actually a neurological condition, and I know that more body areas are involved in the autism, but right now my area of focus is on the brain. So we're talking about neurological applications. We know that we don't exactly know what is the cause of autism. So we're not trying, with this technology, we're not trying to find the cause of this. We're simply saying others are working on finding the cause. How can we help you now with your individual who's struggling and with whom you're struggling? How can we help you by looking at the function of this person? Consider that this is a medical condition. It's not a psychiatric condition. It's not a mental illness. There's actual brain dysfunction. Let's look at it, and how can we give you a clue about what's the next best thing to do? And just so that you know what's happening is we're going from the standard anatomy picture. So this is a cross-section of a human brain. Obviously, this one is post-mortem, but because we're not doing any brain biopsies like this in vivo. But just what I want you to just get, again, the concept over here is how do we go from knowing what this brain was doing? If we just do an anatomy scan, which is the MRI, it gives us great detail of all the soft tissue in here. How do we get to looking at functional information, which happens to be displayed in this color scale? I'll describe some of these things to you. I just want you to get the concept here is this, is that this is the anatomy scan, and it looks okay. And a lot of people talk about, well, what's happening about all the connections, which are these white areas in the brain. In other words, the brain cells that are actually doing a lot of the work are these gray zones, and that's why they're called the gray cells. The white fiber tracks over here are the connections. So this is kind of like thinking of a computer. There's the wiring between the computer chips. Then there's the computer chips out here, and also what is the software that's running in those computer chips. So we're looking beyond the connections. We're actually looking to what's going on in the cells themselves, and we have some scanning techniques that enable us to tell you which areas of the brain are functioning at a higher level or a lower level. what is typical and what's atypical. Now, I just comment just briefly about the fiber tracts over here because the most prominent person that you and I know in the autism world is Dr. Temple Grandin. And last year when she was giving a presentation, she showed this slide. So I'm going to show 2 slides about her, and I'm using them with her permission. And she said, wow, she got this scan of all the fiber tracts in her brain. And she said, well, because of knowing this, and remember, Dr. Grandin is very much about structure and relationship. So to her, this helped her to understand, especially when she pointed out, she said, if you take some of this information apart and you just look at certain specific areas of the fiber tracts, she said, look, in her, they discovered that she has a lot more connections in the fiber tracts than does the sort of normal age-matched subject. Now, that can tell you something about how somebody's brain is working. The point I want to make, though, is that, remember I said the white matter is the fiber tracts. What this approach does not do, it's not bad, it's not wrong, what it doesn't do is it doesn't tell you what's going on in the brain cells that are all the way around over here. You literally don't know what's happening. Now, clearly, if there's some breakdown in the communication pathways and the connections, there's going to be some dysfunction. But the key issue, what we're focusing on, is what are the brain cells themselves doing beyond just the connection. So we're transitioning now from looking at, this is the real anatomy, the MRI aspect of that. We're going to talk now about how do we actually get these functional images. It's time for me. Every now and then I get pretty intense. So I just remind myself to take a little sip of water, and then we'll proceed. And incidentally, just to have some fun, is that anybody ready to pick my brain? Another one on this side. Talk about tossing out ideas. Okay. So just like a schematic diagram, just so again, that you can get a handle on these things. In the world of medical imaging, so we're talking about all standard medical imaging now, is that we're basically looking is, are we looking at the structure or the anatomy of things? Or are we looking at the function of that brain structure? The most common approach in the anatomy world is using MRI scanning. It gives you great depiction of the anatomic details, but most of the disease processes actually start at a cellular level, and by the time that you can see them in macroscopic imaging, which is what MRI is that 20 million cells or something could have been impacted and be defective, and you still don't necessarily see that anatomically. So it doesn't mean, my point over here, there's no value judgment about here as to one technique being better than the other. I just want you to get that there's a variety of technologies out there. We just simply need to look at what's the most appropriate tool to use now to answer a specific question. In the area of autism, because there's a lot of cellular dysfunction, we're focusing more on function imaging rather than anatomic imaging. Now, some of the benefits of this also, so the most prominent type of function imaging is SPECT, stands for single photon emission computed tomography, and I'm not going to describe all the technology aspects of things. So this is the most common form of brain function imaging. It's more readily available and more common than using PET imaging. Thing that I want you to just notice is that this data is based upon cellular function, and the images actually give a rate of function. So what we have is that we can actually make some quantitative analyses of the data, so that this is beyond just simply my eyeball or some physician's eyeball evaluation of whether the scan looks normal or abnormal. We can actually extract functional information in a quantitative way, and so there's some objectivity to this. And remember, when we're looking at the function, we're not necessarily thinking of any one specific diagnosis, although that may be like the pertinent clinical question of the moment. And inside these technologies is that there's just to know is that there is one form of MRI that's called functional MRI, fMRI. It's not too commonly available. It's not reimbursed. But the important point I want you to get, again, just a take-home point, this requires a cooperative patient. One of the advantages of SPECT imaging is that it actually doesn't require a cooperative patient. In other words, patients can be sedated if necessary for the procedure. Now that has everything to do with the fact is that the SPECT scan is based upon what the person's brain was doing when they were injected with the isotope for the scan, not what the brain is doing while they're in the scanner itself. Okay, that's the key point, is what was the brain doing when you were injected, not when you're in the scanner. Which means also it gives us some advantage, namely is that we don't have to do these scans, that is the injections, at a baseline state. The most common thing, of course, is to do it when the person is relatively quiescent, but we can actually inject patients while they're doing a cognitive challenge and see how the brain can respond, or hopefully can respond to a certain challenge test. And I'll show you an example of that during the course of the presentation. And I usually give this talk to a variety of groups. So bottom line, I'm not going to talk about all the differences of these technologies. What I did show you about temporal Grandin is known as tractography. In other words, what are the fiber tracts? You hear words like diffusion tensor imaging. That really has to do with how do the water molecules migrate in the fiber tracts. Again, I'm not talking about all this technology here today. Just want you to have an idea that when you hear about diffusion tensor imaging or what have you, it belongs in this compartment over here of anatomy imaging. Now, one thing that does happen with using this form of imaging, that is even looking at fiber tracts or fMRI, they can really only measure one thing at a time. In other words, one function. It may be just some aspect of speaking, some aspect of reading. They really only measure one function at a time, and these sequences usually take the better part of 30 to 40 minutes. One of the advantages, in contrast, and one of the advantages of SPECT imaging is that when we inject the person, that injection goes to all parts of the brain. So when we do the image of the brain, we're looking at all the functional aspects of the brain simultaneously. So even though you may have a question about how's this one part of the brain working, the real question is, well, what's the rest of the brain doing while that's going on? As you'll see, is that there's a number of factors that are going on in the brain, and even though you may be interested in knowing why the person is anxious, the brain SPECT study can also help you to know, well, this person previously had some traumatic brain injury, so there's more than one thing going on in this person, more than one thing about which you need to help them, even if you focus on one specific thing at first. So functional imaging, we're actually looking inside the body. We're seeing actually biochemistry. That's what's going on here. Remember, there's some quantitative basis to it. It's an objective form of analysis that I'll show you. So it's not just my eyeball and my gut sense about what's going on. And we're not just looking for any one diagnosis. Now, there's 3 technologies that are actually required in order to accomplish any form of complex brain imaging. In the case of SPECT imaging, we've got to have the hardware. So this is where the SPECT comes in. That's the machine. Okay? Now, in order to make this work, we have to inject the person with something. It's a radio tracer. This is how the biochemistry gets to be observed. An important point here is, again, they're called radio tracers because this is based upon the tracer principle. We're injecting such a trace quantity that you cannot actually measure it in terms of grams or picograms. So this is a tiny quantity. And the purpose of this is that its distribution then, because it's such a minute quantity and yet adequate for imaging, it's such a minute quantity that it doesn't disturb the organ function that we're trying to measure, because that would obviously defeat the whole purpose. A lot of the contrast materials that are used in CAT scanning and MRI are actually pharmacologic loads of various substances that are really not metabolic or function imaging per se. So yes, we've got to find some way with a machine to find where the tracer went, and then we have to have some software that enables us to extract the function information from that data. If any one of these parts isn't working very well, you end up with a lousy scan that doesn't tell you a whole heck of a lot. What this also means is this is moderately complex and expensive technology, and as a result, these scans can never be priced at this point in time in terms of like $250 a piece. I mean, it costs more to just simply do all of this technology. So we're injecting in the radio tracer, and as I said, either when the person's resting state, and that's as true about most of the kids on the autism spectrum, they're sort of resting. Usually when we do the injections, they're sitting on their parent's lap, in what way the child can be most quiet. Every now and then we've done some cognitive challenge tests, and so I usually just have the parents give them a challenge of whatever they've observed to be challenging for their child. Usually this is sort of like reading or focusing on some pictures or what have you in order to do the challenge part of the test. Now, one of the advantages is that, or let's put it this way, in order to get this functional data, we need to sample for a certain amount of time, and that's about 20 minutes. Most of these children, of course, can't hold still for 20 minutes, let alone 2 minutes. So we do use intravenous sedation on about 80% of these patients. We use propofol, and yes, I can tell you that we've scanned more than and sedated more than 1,000 of the children. We use anesthesiology personnel, so this is a completely safe approach. And I know that all of you are concerned about, is there any sort of possible metallic component to this? The answer is no. One of the things we've observed, even with the sedation, we don't cause any regression, because that's, I know, is a big concern of parents. Nothing's going to cause my child to sort of like lose some of the function they've already gained. So not to worry about that. This is what a SPECT scanner looks like. So it's not like an MRI, a big tube. What it is the person is laying here on this scan table and they're out in the open. Notice that. If there's any sedation personnel, they're working right alongside the person over here, complete access. The head is just held in this sort of a sling-like device, and there are 3 imaging, they're called camera heads. So it's just like 3 giant lenses looking. They're all focused at the brain or the head over here, and what's the brain uptake right with the head placed over here. These devices slowly cycle around the person's head over a period of 20 minutes and are gathering a 3-dimensional volume of function information. That gets sent to the computer, where the computer slices and dices it with my help or that of others. And then we make subsequent images. And what those images look like, one other thing, radiation dosimetry. Notice, compared to a CAT scan, the radiation dose from a SPECT scan is of certainly much less degree. So we're cognizant of the fact we're not doing SPECT scans on children every month. There is some radiation exposure, but most people never hesitate if the child had some sort of injury to get a CAT scan. Well, the CAT scan dosimetry, there's nothing wrong with it, but it just takes a whole lot more radiation to do CAT scanning of the brain than it does to do SPECT imaging of the brain, just to reassure you. Now, the findings that we observe are really in 2 basic categories. Remember, we're not looking for any one particular diagnosis. We're just looking for where are the areas that are underactive, where are the areas that are overactive. And as it turns out in our clinical experience, 90% of patients basically show both of these things. So the question really becomes, what's the more predominant factor? Is it an overactivity or underactivity? And then based upon that, what kind of helpful therapy judgments could we make? Let me just stop and wet my whistle. Now, there's a variety of presentations for these scans. The most simple form of this over the last 20 years has been just to use what are known as surface maps So these are a person's brain function. So this is not their brain. This is actually a depiction of the isotope distribution in this person's brain at the time that they were injected. And this is simply looking at it. Remember, this is all in the computer. So we have like a three-dimensional volume of information. So we can look at it from the front. So it's just like as if you were just looking at me. My right eye is down over in this space. Left eye is over here. The temporal lobes are along the temple area. If we look at the back of the person's head, here's the back of the brain. Because it's in the computer, we can look as if we're standing on top of the brain, or we can look from as if we were standing underneath the brain. In this particular case, there is some abnormality. So in this imaging type of output, this image is thresholded with the thought of find the areas that are below function at a certain threshold magnitude. In this case, that happens to be in these parts of the temporal lobes, which are at the bottom of the brain. So we're looking, we're standing up, looking up at this brain. The temporal lobes in this person they're not missing. It's not that the tissue is missing, but the function of those tissues is missing. This person has normal anatomy, but their temporal lobes in terms of uptake function is below what we would expect. Also in the orbital frontal areas, in other words, the areas that are just above your eyeballs, there's some decrease over here. Also the back of the brain, which is known as the cerebellum, there's a lot of irregularity in function there. And in fact, this is like the most common pattern that I see in individuals on the autism spectrum. And this has been the conversation for a long time. And the assumption has always been that if the brain isn't working properly, then it must be under-functioning. So a lot of the conversation about findings over the last 10 to 15 years is hypoperfusion, under-functioning brain. As you'll see, that's not necessarily so, because in this individual, the computer assigned some values, and we said to the computer, tell us what are these below threshold values, which you've already seen. But what if we take this data, because it's quantitative, and we say, just tell us the top 15% functioning cells in this person's brain. How many are there? Well, it turns out, and this is just 2 views, obviously we have more views than this, these red areas are all areas that are over-functioning. So this is a person who, as I said, this is like the combination of areas of decreased functioning, areas of increased functioning. Based upon this information, we now have some more direct information. In other words, we're just looking at the brain and saying, tell us what's working, to what degree, under-functioning or over-functioning. And we're going to talk a little bit about what we would do based upon this information. And this is independent of whatever is the behavior observation of the individual. And this is independent of any diagnosis that you might have clinically. Now, there's a little bit more elaborate display, but the fundamental thing, again, just to get, and you'll see this slide again, but the point is that we can not only look at this 2-threshold model, high, overactive and underactive in a baseline state. We can also look at how the person's brain responded when they were in a cognitive challenge activation state. In this case, there's not much difference. I'm going to show you this slide in a clinical format just shortly, but I just wanted you to get the sense of areas of underactivity, overactivity, doing it in a baseline state, looking at it with a cognitive challenge. What all can we learn? And yes, there's even some more elaborate displays of this. And what's important, because remember I said we're looking at function. So a variety of individuals, and it includes Dr. Henderson, my colleague who's present in the room. What it was done is that we got away from just making grayscale images. If you are going to get any SPECT scans on your individuals, they've got to be able to image you beyond this grayscale capability, because there's a whole bunch of functional information, and if you don't know how to extract the information, actually happens to be a physiologically based color scale. If you don't have access to this kind of software, you won't extract a lot of function information from just these eyeballing the grayscale images. This data, because it's quantitative, can even be put in and compared in a database system. So if you have some reference population, you can actually grade on a per picture element basis. Is that area sort of within 2 standard deviations of a reference patient database? Is there in any area that's over that comparison that would be color-coded in red? In this case, this is just a display of somebody who is areas in the right side of their brain. So this is the right lateral view. The back of the brain is here. Front is here. Here's the temporal lobe, sort of this semi-hot dog-shaped area. There's a lot of green and blue in here, and based upon the physiologic parameters, these are areas of function that are 2 and 3, sometimes as much as 4 standard deviation below what the reference database would say it ought to be. This helps us to get not only a sense of what's the anatomic dimensions of this, but also is that what's the magnitude of dysfunction. And yes, we go beside, or we transition from just making cross-sectional slices. This is the same patient data. This is the 3-dimensional presentation of it in views that are the right side of the brain, the left side of the brain, the front, the back, looking down from the top and looking from underneath. That's the same information that's here. It's just most people find it easier to get an overall sense of things looking at the 3-dimensional approach to things rather than looking at multiple cross-sections and trying to add that together in your mind. Now, remember on this color scale, there's a gradation of function in here. And any area that's at about the 40% cutoff level is color-coded in black because clinical experience is that if an area of the brain doesn't have more than 40% of uptake based upon this type of scanning technology, that's probably not viable tissue. So this is a person who had a stroke. And this is a person who's left side of their body. This is the right side of their brain. So the left side of their body, they have a weak function of their left arm and left leg. The take-home message over here is that you could tell this by just looking at the person. So what good is the brain scan in this case? Well, what the good of the brain scan is what is the rest of the brain doing while the person is dealing with their left hemiparesis? This is a person who's been like this for 2 years clinically and has had every bit of physical therapy, occupational therapy. Nobody was really paying attention to the fact that the rest of the brain has this variable function pattern. So not only does this person, and this happens to be a 20-year-old person, who gets to us for scanning and hyperbaric therapy 2 years after the onset of this stroke. It actually happened to be an accident that ruptured her blood vessels. But the point is that people weren't really thinking about what's happening in the rest of this person. She not only is weak on the left side of her body, but she can no longer go to school. She couldn't stay in college. She couldn't drive, and she didn't have much of a life because other parts of her brain were not working. But nobody really thought very much about that until you say, what's going on in the rest of the brain? That's one of the good things about this technology. We're looking at all the aspects of brain function in the person, not just one clinical diagnostic concern. And these are just other examples over the course of events. This is that same person. Here we were imaging a lot of children in the cerebral palsy spectrum. Some of them have areas of the brain that are just absolutely not working, and we don't know how to make them work. Here's somebody who's had a near drowning episode. So remember that in the color scales that's in the green and blue zones, all of this is under-functioning brain in this person who was underwater and suffered a near-drowning event. Checking in again and also wetting my whistle. And also is that there's one more brain here that needs a home. Okay, if any one of you want to get to, please, we have a booth right out in front, the Neurolumin's right in the other room. And we've got plenty of brain balls. Okay, so as I said, most of the conversation initially was in individuals on the autism spectrum, how much of hypoperfusion underfunctioning is there? Now remember that the brain doesn't store its energy source, so it needs a continuous blood supply, and the blood supply and cellular function is very closely linked. So if your brain cells need to function fairly abruptly to do something, it recruits blood flow to get sugar and oxygen there right away. So there's a very close linkage. So therefore, this physiology of using a tracer that goes to the brain based upon blood flow and cellular function just simply physiologically works. And yes, a lot of the conversations and papers that were published initially said, wow, there's decreased blood flow, there's decreased blood flow, there's decreased blood flow, so forth and so on. But it was in the last 10 years or so that we began focusing on areas of the brain that have increased uptake, increased function, and observing and making clinical correlations with what does this mean in the autism spectrum individual. And the answer is that we're finding that there's a lot of what we call comorbidity issues, or what you could just call co-occurring factors. In other words, even though the person may have certain behavior manifestations, remember the scan is telling us what is all going on, not just one thing that we're interested in knowing. So what we're finding, and I'll mention some more about this, but what we're finding that those areas of increased activity, those comorbidity or the co-occurring factors, can indicate that there's an unknown underlying seizure focus. This individual suffering from anxiety but can't tell you about this. We've seen episodes that even look like post-traumatic stress disorder. Why is this child spinning around in a circle for 2 hours? Well, we can show you what part of the brain is overactive and what suggests what you might do about that. The goal over here, remember, in this approach is to look at brain function and say, how does that tell us how best to deal with the circumstances in this individual at this time? So hypoperfused areas are decreased functioning, hyperperfused, increased functioning. Comorbidity issues, as I said, have been shown. This has been our clinical experience of seeing seizure foci that don't show up on the EEG. The EEG is surface monitoring technology. You simply won't find all, there's nothing wrong with EEGs, okay? But they don't find all the seizure foci. The scan doesn't care what's going on the surface because it looks through the entire brain, top to bottom, front to back. If there's a seizure focus deeper in there, we'll still see it, even if it's not on the EEG. This said, we've seen a variety of dysfunctional behaviors, and we're even seeing things that are sort of like the equivalent of mood dysfunction. And yes, I'll show you an example of some individuals who were misdiagnosed as being attention deficit disorder, but were really on the spectrum. So just reminding you about the imaging technology, and we're using color scaling that has some physiologic meaning. Areas that are brighter colored, red or what have you, are overactive. So these are areas that are overactive. This is not abnormal. This happens to be your visual cortex. It's the back part of your brain. Whether or not your eyes are closed, when you are thinking about looking at something, the visual cortex in your brain lights up. So this is a normal finding. Now this is an example of looking at cognitive challenge testing. In other words, here's a baseline scan on a person, and this is that same person while they're doing a cognitive challenge test. They're basically looking at a computer screen. They have to follow various things on the computer screen for a period of 10 to 15 minutes. Or in children who can't do this, then we just have them follow various colored pictures or whatever the parents think is an appropriate challenge. So under usual circumstances, typical function, we're not saying there's anything abnormal here. Typical function is that, and red shows more function than just the yellow colors. That's the color scale. So this person is doing what is typical. When you and I are challenged with some cognitive challenge in front of us, we should be able to recruit our frontal lobes to process that data more effectively. But what happens if that another person is doing that, and in the baseline state they look like they have very good perfusion, and whoa, wait a minute, remember green is below, sort of at least one standard deviation below. This person's frontal lobes can't recruit the frontal lobes to perform that or deal with that cognitive challenge. This is at least what the scan pattern looks like in those individuals who have some type of attention deficit disorder. Now, again, we're not making a diagnosis per se and labeling people with a diagnosis of this. The point is that clinically, this really means something, that this person is really challenged and they can't keep up with and process data that's coming in as quickly as one might expect that they should. Now, this is an example, not of before and after, but one of the things that Dr. Henderson has said, well, you know, one way of speaking this is that we're reframing the expectations about treating the symptoms of autism. In other words, we're reframing that. How else to think about this, look about this? And the answer is, for example, is here's two different children. They both had a very similar clinical presentation in terms of delays of speech and social reciprocity, so forth and so on. One child has areas of the brain, now you know blue is kind of bad, so one child has a whole lot of underactive areas in their brain. The other child has areas at the front and back of the brain that are definitely overactive. Wouldn't it make sense to at least think that maybe the therapy for this wouldn't be the same as the therapy for that? That's just thinking about that. That's a take-home point. So as we look at the scans, we're saying the brain is telling us what is probably the next best thing to think to do to help these people. And so I get a lot of questions. You know, what's the cost of getting a brain scan? And why would you spend money on a scan when you could just spend money on therapy? Now, look, I've talked to a lot of parents, so I know that you're all paying out of pocket for a whole lot of these things. So every decision that you make has a cost factor to it. And so you're going to make some decisions and say, well, why would I spend money to get a scan? I could put the money into therapy. Now, most scans are going to be, I'm just going to hold questions to the end. Most scans are going to cost a better part of about $2,000. This is not inexpensive technology. We have no control over the fact that the company that provides the scan tracer over here charges $1,000 a dose. And I won't talk about corporate greed of a company that starts with G and ends with E. Okay. But the purpose of getting the scan is that many of the causes are multifocal. There's different aspects are going on. There's multiple comorbidities. So at certain points in time, if a child's therapy, for example, or an adult person who's had a stroke and isn't getting anywhere for a couple of years, that would be a time to get a scan to look to see what all is going on. And this was such an example. Remember, this is the gray scale where these are areas below activity. These are areas that are overactivity. And the answer to this test question is that this is one of two boys whose mothers brought them in to me and said, would you please do a scan on them? We've been treating this child for 4 years with stimulant medications, and they're not getting better. I'm desperate over here. What can we learn? How can you help us? Well, simple, just because of time. There were areas, as usual, that were below activity that fit within the autism spectrum, and this mother didn't know that. There were areas in the brain that were not decreased, and when this child did a cognitive challenge, they did not get worse. So this scan pattern at least doesn't fit with a diagnosis of attention deficit disorder. There are multiple areas in this child's brain and the brother's brain that were, as you see, these bright areas are overactive. So was it not a surprise once you learn the function information? It should not be surprising here to know that this child didn't need stimulants. And in fact, if you put stimulants in this child, they're going to function worse. This child doesn't need stimulants. What they need is how do you help these other parts of the brain that are underactive, and how do you sort of cool off these areas that are overactive? And the take-home point message from Debbie is, she went through an effort to do this, and she said, prior to having a SPECT scan, I felt like we were navigating my two sons' important neurological situations in darkness. This is the pre-scan finding, 4 years of stimulants. After completing the scans, my children's unique challenges were illuminated so that targeted treatments could be developed. But here it is from a mom. I wish we would have started with a SPECT scan 4 years ago. It would have saved us a whole lot of frustration and time and money. So, and there are other costs involved with this too. If you're, all the suffering and the frustration of dealing things for years without knowing clearly what's going on in terms of brain function. And we know that in terms of helping children, it's better to intervene sooner rather than later. So sort of the general concept is getting this information sooner rather than later can simply be helpful. We've talked about this to some degree, and I do need to be wrapping. One thing, though, I do want to point out to you, and this is, you can't, even though the SPECT technology exists in multiple hospitals throughout the country, because SPECT is just a machine, the reality is that not everybody knows how to do SPECT applications of the brain, and to do that in children, and to know what that could mean to somebody who's in the autism spectrum. So the bottom line is that although every SPECT scan could be clinically useful, sometimes they're not because they're not done with sufficient anatomic detail. Other times they're not because people don't know how to interpret them in terms of what's going on in your child. And this is an example of a scan. If you got a scan like this frequently, the readout with this would be if somebody who didn't really know how to extract the data. There's nothing bad or wrong here, but it's like if you don't have sufficient technology and you get a scan readout, many times scans like this are read out as nothing really abnormal or within normal limits. But remember, that report is a legal document that says, and your individual who has atypical brain function, somebody said, we don't see anything abnormal here. It's not good to have that kind of document on the record. So you either get a SPECT scan that's really good or don't get one at all. So Dr. SPECT Scan says, one of the recommendations is get a SPECT scan on your child only if the imaging site actually does brain SPECT scans. They actually have done a couple of dozen cases, so they clearly have some clinical experience. They know how to sedate the child safely in case that's necessary. And when they look at the scan, they're interpreting the scan in terms of the clinical context was, what does this mean for the individual who's in the autism spectrum, or the individual who's had a traumatic brain injury, or the individual who's in the older age individuals where the question is about dementia or stroke. These have to be interpreted in the appropriate clinical context. So bottom line is we do have modern medical imaging technology that's not experimental. We can actually use that to look at and characterize brain areas that are underfunctioning or overfunctioning. We can tell you about the magnitude of that process. We can also give you some clue about what that means clinically so as to guide you into terms of what's the next most appropriate therapy. So these are the last points. Number one, how can we ease the stress? And it's not just of the individual. I know all the families are stressed like heck. When I talk with parents, I say, I get that, like for you, this is 28 hours a day and 8 or 9 days a week to be with someone who has a typical brain function. So we can help to ease some of the stress and the burden, because if we uncover a seizure focus, that can be treated. We can uncover areas of traumatic brain injury. Your children are not necessarily traumatized, but the reality is a lot of them do some head banging. The brain is very soft. It's easy to injure it. There's some unknown traumatic brain injury factors. We can help you find improved temporal lobe function, which may result in some improved languaging. The cerebellum at the back of the brain has 50% of the cells in your brain. It's important to have that functioning appropriately for sensory integration. We can uncover anxiety areas. And I see the person coming with the hook. So then this is the last point, is it? So we can discover areas that would help you to understand why this function looks like there's some attention deficit disorder, but it's really cognitive inflexibility because another part of the brain is actually overactive. We can help you understand, just areas that are not responding to present therapy. And in fact, when would you use a scan? Bottom line is, you said, this is not a screening procedure. So when you're going to use the scan, my recommendations basically are when a person has gone through whatever form of therapy they have been, and you've been on that pathway for a while, whether this is stroke management or autism, what have you. If you've been on that pathway for months, hopefully not for years, and things aren't changing, could be time to actually look to see what the brain is doing and what that tells you is the next best step. Second time to use a scan is that, well, we've already done something. Let's say this is before a course of hyperbaric oxygen therapy, which could take the better part of 2 months. You might want to have a baseline scan to look at what's all being treated, such that whatever you subsequently do, you've got a baseline study to say, at this moment in time, on this scan, we knew that these areas of the brain were doing whatever they were doing. And if you did a subsequent scan, we could see if things changed, improved, or if you need to modify the therapy that you're using. So this was a quick overview, but I do want to thank you for using your brain function. If you want to know more about our services, nlbrainhealth.com, because we're actively involved not just in autism, but helping people with chronic fatigue. We know that in family members, there's elements of stress, mood dysregulation, chronic fatigue. We can help people in addition to those who are just in the autism spectrum. We can help you with various other behavioral medicine disorders. We even have a new form of depression therapy that time doesn't permit us to describe right now. But Dr. Henderson is here, and we're open to questions. We're in the booth over here. We would like you to know that you really can take a look to see how brains are working, including your brains, and get yourself some direct, objective information about what's the next best thing to do to understand this situation. I thank you for using your brain.